Okay, so good morning everybody, or good afternoon. I'm going to move to my second talk of this meeting, really focusing on lipids and cardiovascular risk and the importance of treating to risk, and what do I mean by that. With guidelines in particular, we look at populations and we talk about what it's reasonable to do across the board in most of our patients, but you and I see individuals, and that's really where the challenge comes, and this is where every additional comorbidity, additional variable really does count. And if we were to think about personalized medicine, that's really what we should be thinking about focusing on. So these are a list of my disclosures. So let's start with this slide. And none of us would disagree that hypertension is a risk factor for cardiovascular disease. So if you look at the colors here, these are individuals with differences in blood pressure ranging from 110 all the way to 180. Now, if you look at the reference group, of course, 180 is higher in terms of risk. This is event rate, 5-year CVD risk per 100 of the population. Of course, 180 carries more risk than 110. But it's the background of other factors that will determine the absolute impact of that 70 millimeters of mercury difference in blood pressure. So if you don't have diabetes, if you're a non-smoker, if you're female, if you're relatively young, total cholesterol 160, HDL of 60 milligrams per deciliter, that difference may be about 2%. Now, if you start to add additional factors, so this is a total cholesterol of 280, smoking, HDL of 38 milligrams per deciliter, gender, male gender, diabetes, another 10 years, that same difference in blood pressure now increases your risk by about 22%. You go from 22 to 44% risk. So the person here with a blood pressure of 110 has a higher absolute risk with all of these factors in the background than the person here with an isolated risk factor. And that's really this important concept of global risk, which is important when we think about add-on therapies in particular. So let's look at some registry data. So the idea of this large REACH registry, almost some 20,000 or so individuals, is to look at event rate in general populations with and without vascular disease. Now, these are individuals with risk factors only, and they're broken down by those with and without diabetes. And then you've got people who've had an acute ischemic event, and then you've got people with stable presentations. So acute ischemic events, highest event rate, stable disease, slightly lower, and risk factors only, lower still. But within that group, there's a mixture. If you have diabetes or polyvascular disease, it differentiates between whether your event rate is here or here, and so forth. So it's actually important to look at what else is present before trying to get an idea about how aggressive one needs to be. The next thing that's important is if you've got an acute ischemic event, it's the proximity to that acute ischemic event. So if you break down those with a prior history of ischemic disease, those with the event rates in the previous year are at higher risk, slightly lower if your acute event was further off, but considerably higher than those people with a stable manifestation. So these are the type of things, and this is all-cause mortality, this is CV death, non-fatal MI, stroke, composite endpoint. So the same type of pattern is true across the board. Now, why is this important? Well, this is important because let's say in a room like this, your annual event rate is less than 1% a year, so 5% risk, less than 5%. If I lowered LDL cholesterol in this room by 40 milligrams per deciliter, just across the board, I'm going to prevent 6 cardiovascular events. If instead I decided to lower it by 100 milligrams per deciliter across the board, I'm preventing 12 events, 6 more. But if you all left and a new group sat in this room with a 5-year risk of 30% or annual risk of 6% per year, now that same 40 milligrams per deciliter, because your risk is so much higher, is going to prevent 61 events. And if I now change that to 100 milligrams per deciliter lowering, I'm now preventing 142 events in this room. So basically, the higher the level of risk, the benefit from that first intervention, but also a greater benefit from going lower with LDL cholesterol. And the same is true for vascular deaths avoided if you think about a population. So in the recent iteration of the ESC EAS guidelines, because, and I'll show you this in a second, that we've got progressive data about lower being better and also about what constitutes high risk, there was really this update into defining people not just as high risk, but very high risk, defined as those people with any clinical manifestation of vascular disease, but then we're interested in event rates. So the question then becomes, the patient with diabetes, what additional factors do they need to have a 10-year event rate that is comparable to someone with established cardiovascular disease? And the thought is that these are people with diabetes with evidence of end organ damage, or in people with type 1 or 3 major risk factors. So either end organ damage, 3 major risk factors, or type 1 diabetics who've had diabetes for more than 20 years duration, severe renal disease, primary prevention with a 10-year mortality rate of 10%, and people with familial hypercholesterolemia with established cardiovascular disease. And if you then look at the next group, those with high risk, you'll see that these are all now primary prevention patients. Now, high risk, moderate risk, and low risk. And amongst the high risk group are patients with diabetes. Now, instead of looking at people with evidence of target organ damage, diabetes without target organ damage, and with duration of diabetes maybe more than 10 years. So again, it's this estimation from population studies of event rates in the general population. The renal threshold is somewhat now more relaxed, so you look at EGFRs between 30 to 59, and you've got now a global risk score of dying of between 5 and 10%. And so the risk categories just change using population data to identify characteristics that predict a certain event rate. Now, why is that data come in for the microvascular disease? And this was some of the work that we did using large-scale electronic health records in the UK. So the first novel observation was that if you could have only one manifestation of microvascular disease, whether it was nephropathy, or retinopathy, the hazard ratio for 3-point MACE is roughly the same and independent of duration of diabetes. So the next question was, could you add those up sequentially to predict event rate? So if you look at this slide, this effectively is 10-year event rate. So if you don't have any microvascular disease, in the next 10 years, your event rate with diabetes per se is 5% over a 10-year period. And it doesn't matter which of the microvascular disease manifestations you have, you almost double it. So you get about another 5% increase in risk. If you have 2 of these, it's now another 5%, so 15% risk. If you have 3 of these, it's a 22% risk. The same is true when you start looking at the relationship for cardiovascular mortality, ranging from 1.5% to all the way to 10%, and also when you look at hospitalization for heart failure. So you can use those basic simple clinical characteristics to identify the high-risk patient. And why is that important? These basically look at all your goals achieved, so that's an LDL of about 100, HbA1c now not controlled, other risk factors, BP and LDL controlled, 2 risk factors not controlled, all 3 uncontrolled, and you'll see if there's no microvascular disease. Of course, controlling these is important, but it becomes less important over at least this observation period because there isn't much risk to start with. In contrast, if you've got microvascular disease, 3 manifestations, it becomes really important to control each and one risk factor. And that's largely why that comment is there in the clinical guidelines. Now, this is really the take-home message from the ESC EAS guidelines and the European Heart Journal. It's free to download. You can get this slide deck quite easily. But it's a very simple concept. This is your assessment of the patient sitting in front of you in clinic. Are they low, moderate, high, or very high risk? and then to match the level of LDL cholesterol. LDL is the primary target, so if you're low risk, I'm aiming for an LDL of 115 milligrams per deciliter, moderate risk, 100 milligrams per deciliter. If I'm high risk, that's been changed from 100 now to 70 milligrams per deciliter, and for very high risk, that's been changed from 70 to less than 55 milligrams per deciliter. But the first thing you will see is the importance of achieving a 50% reduction. Why is that? Well, there may be patients who develop a myocardial infarction with an LDL just above this target. And you and I know you could give them a tiny dose of statin and achieve that target really easily. But that's not going to be enough. If somebody's getting myocardial infarction, stroke with really risk factors that you don't think are that bad, then they need a much bigger reduction. And that's why the first aim is to achieve a 50% reduction by optimizing the dose of statin therapy and then trying to see how far you're away from goal. So after starting statin therapy, if you're not at the goal, your next step is to add in ezetimibe, which may offer another 25% reduction. If you're at goal, great. If you're not at goal, then you might think about a PCSK9 inhibitor. And part of the rationale for this is that we know the monoclonals are more expensive, therefore we really want to be using it in those patients that are at highest risk and therefore may benefit the most. Now, diabetes is obviously a unique scenario because we know a lot about the diabetes dyslipidemia, and this is manifest by abnormalities in HDL, typically lower HDL cholesterol, lower ApoA1. We know that they have higher triglycerides, and therefore they also have higher ApoB containing lipoproteins and more small dense LDL. So for the patient with diabetes, LDL may not completely capture all of the residual risk, lipid-related risk in those patients for these very reasons. And so there are comparable non-HDL and ApoB targets depending upon the level of risk. So, for example, for our very high-risk patient, one would aim for a non-HDL. So if the LDL was 55, the non-HDL would be 70, and the ApoB would be 75 milligrams per deciliter. That's for the very high-risk patient. And again, similar corresponding non-HDL and ApoB levels for the high-risk patient, and then the moderate-risk patient up here. So again, it's this concept of get those lipids, atherogenic lipids, to match and titrate to the level of risk in the individual patient. So if we now look at what we should be aiming for in these patients, the high-risk diabetic patient, and here we've identified that, the target in that individual is an LDL below 55 milligrams per deciliter. That's the very high risk. In the high risk, we're aiming for 70 or so. And that's the class of recommendation 1, level of evidence A. There's another important caveat within that. There is often a tendency, because we see individuals with diabetes with abnormal lipids, and often there is a desire to treat the intermediate phenotype, the triglyceride, thinking that that will translate into reductions in clinical events. Now, to date, the fibrate trials in particular, added on to statins, have not shown much added benefit. The older trials with gemfibrozil, for example, did show benefit, but certainly that was in the pre-statin era. So there is this recommendation that intensification of statin therapy should be considered before combination therapy. Why is that? Well, this was our data from the TNT trial. And here, at baseline, remember, this is a trial of 80 versus 10 milligrams of atorvastatin. And you can break down the baseline population by fifths of triglyceride. And if you did that, the additional gain from going on to a higher dose of statin from 10 to 80 translates into about a 27% risk reduction. And as TG goes up, you're getting something like a 31 to 40% further relative risk reduction with very large absolute benefits. So it goes back to that slide I showed you. The higher the level of risk, the higher, the greater the benefit from further LDL reduction. And that's why the first aim of these patients is to optimize the dose of statin. So that's the first target, but usually in these people with diabetes and high triglycerides, we should really be looking at non-HDL and lipoprotein B. You'll see that triglyceride, there is no goal as such, but they talk about what may be desirable in those patients, as well as other characteristics that need to be controlled, because we know that triglycerides will improve with weight loss, certainly, and with better control of diabetes. So we've got data that in individuals with diabetes, that lipid lowering per se, in the absence of elevated lipids, because patients with diabetes have high risk, placebo-controlled trials, 2 of these have certainly shown that there is comparable benefit. We have data that in a population with established coronary disease, that high versus low dose statins is actually better with greater absolute benefit. But what about add-on therapy? We don't really have data for diabetes primary prevention, but when diabetes exists in the context of coronary artery disease, we've got really quite solid evidence that actually going to even lower targets is important, and let me show you some of these. So this was the data from the Improve It trial, which compared ezetimibe and a statin with statin alone. And even though the absolute reduction in LDL cholesterol was modest, it's 15 milligrams per deciliter, but that difference is maintained over a 6 to 7 year period. And if you look at the population with diabetes, that they have a 5.5% absolute risk reduction with a statistical interaction term compared to those without. So this led the ACE guidelines to really recommend, they call this group diabetes with ACS, the extreme risk patient. And they were the first to recommend that these patients should have an LDL cholesterol below 55 milligrams per deciliter. We're now in the realm of the PCSK9 inhibitors. And with these drugs, on top of a statin, we can achieve LDL cholesterol levels now lower than what was achieved in the Improve It trial. And we can go down to LDLs of between 25 to 50 milligrams per deciliter. So in the Odyssey Outcomes trial, this was the diabetes analysis, and what we did in the patient population, they were all post-ACS patients. Despite maximally tolerated statin therapy, the LDLs were all above 70, and we broke the patients down into normoglycemia, pre-diabetes, and diabetes at baseline. And roughly the distribution of patients is a third, a third, a third. What was somewhat surprising is that with contemporary therapy and with an average follow-up of about 28 months, 2.8 years or so, that your pre-diabetes and normoglycemic patients, the event rates, although they're higher in pre-diabetes, are not, I would say, that much higher, and normally we might have expected a group up here. But if you look at the people with established diabetes, it's considerably higher. It's almost double. And this was the composite MACE, this is CHD death, this is non-fatal MI, and this is ischemic stroke. For everything except unstable angina, it was higher compared to the other groups. This is the relative benefit. And if you look at the relative benefit, this was the overall benefit in Odyssey Outcomes, 15%, and there was consistency of benefit in each of these subgroups, with no evidence of what we call a p-value for interaction being significant, which basically means the effect here, here, and here is actually statistically consistent. What if you look at absolute benefit? Well, if you look at absolute benefit, patients with diabetes got about a 2.3% absolute risk reduction. So you had a smaller number need to treat in that group compared to these groups. So in the diabetes ACS patient population, this really supports the concept of going down to LDLs certainly below 55 milligrams per deciliter, and probably in the range of about 25 to 30 milligrams per deciliter, as shown by this study. If you look at stable coronary artery disease, and this was the Fourier trial, overall an absolute reduction of about 2%, but breaking the population down by those with diabetes and those without diabetes. People with diabetes have a 4% higher event rate over the duration of this trial, and that's reduced with an absolute reduction of 2.7% and a number need to treat of 37. So a more expensive treatment is more likely to be beneficial here than over here, where the absolute benefit is 1.6% and the numbers needed to treat are almost double. So in the charts of the European Atherosclerosis Society, there is this: assess risk, determine the goal you want to achieve, and look at the starting LDL. Then you can look at, well, how far will I get with moderate intensity statin plus ezetimibe, or a high intensity statin, high intensity plus ezetimibe, a statin plus ezetimibe. So right at the start, you could actually plan out what combination of drugs or monotherapy is going to get you potentially to the target that you want to achieve, having assessed your patient. And finally, with respect to hypertriglyceridemia and potentially treating that, on a background of statin therapy, we really only have one trial, and that was the Reduce It trial with high-dose EPA, 4 grams, showing a 25% risk reduction. And we know that recently the Strength trial with another high-dose EPA did not show benefit. So the results of that, analysis of that, will give us some clues. Importantly, this drug did not reduce triglycerides significantly, and the amount of benefit was disproportional. So it may suggest that actually how you choose to target the patient with a high TG is actually quite important. Finally, I'm just going to finish off with a couple of slides. And we've got to move away from giving everything to every single patient. This is the range of event rates in a population with established cardiovascular disease. There's about 22% people that will have risk above 30%. And you can see a whole distribution of event rates in this patient population. Do we want to give the same thing, 4, 5, 6, 7, 8 drugs to every single patient? We won't be able to afford it. Well, the first thing you have to do is, if this is the dark green in your population distribution, we need to stop them smoking. We need to use the basic first-line drugs better: diet, exercise, blood pressure control, optimize the statin. And then the dark graph moves over to the left, and what you find is now, instead of having 60% of my patients with risk above 30%, that number is now 33%, and more patients are now in the lower risk category. Having then done that, you might want to think about the add-on therapy. So do the basics first, then think about add-on therapy. Are there some simple risk calculators that we might be able to use? Potentially, yes. This is one derived from the Improve It trial, and it just gave people a count of 1 for each of these various comorbidities or exposures, if you will. And there's about 8 or so of these. This is called the TRS-2P score. Event rate in the placebo group goes up the more of these you have, unsurprisingly. But if you look at benefit from ezetimibe in the Improve It trial, the more of these you had, so if you had a TRS-2P risk score of greater than 3, that was the benefit, that was the number need to treat with ezetimibe to prevent one event. This was the intermediate risk group, and that was the benefit, and this was the number need to treat. 2% absolute benefit, this was about a 7% absolute benefit, but very little here. So these are things that can be used, and that's also been done for the Fourier trial and the PCSK9 inhibitors, Alirocumab. So here, again, if you've got a high TRS-2P risk score, you've got a higher benefit, 3.6% absolute risk reduction, numbers need to treat 28, intermediate risk, 1.9% risk reduction, numbers need to treat 53, and here the benefit is much smaller, the placebo event rate is much lower, and the number need to treat is 83. So that's really, I think, what's needed in our routine clinical practice, and there are some attempts to try and do this, but they are merely a starting point, and I think we'll see that being refined. So in summary, clinical care really starts with an assessment of absolute risk. The ESC EAS guidelines have identified this very high risk group, which mostly consists of secondary prevention patients, very high risk primary prevention patients. The first aim is to reduce LDL by 50%. Then think about add-on therapy, meaning you're trying to titrate the LDL to match the risk of the patient. First option is high-intensity statins, then ezetimibe, and then PCSK9 inhibitors. Right at the bottom, consider high-dose EPA for those with high TG after optimizing statin therapy. And the simple take-home message was, if it was direct-to-consumer marketing, is achieve the LDL that is right for you and your patient. Thank you for listening.